Welcome back to Beyond Well. I'm Sheila Hamilton, and this is a program for people who want to find out more about our interior lives. And if you joined us last episode, we were talking with Dr. Stuart Ablon of Think Kids at Massachusetts General and Dr. John Puls, the psychotherapist and clinical director, about the reasons behind family blaming, the roots of it, how it showed up in modern psychiatry, and what a more collaborative, compassionate approach might look like. Dr. Ablon, you are the expert in collaborative problem solving. Why would this model be helpful in these instances for both clinicians and families to learn it, to understand it, and try to achieve it?
Well, I think in the last episode, Sheila, you said it well when you said, more collaborators, more helpers can only be better, right? Yes, they can, as long as they're not working across purposes.
Right.
And when we sort of cast blame, and when we sort of try to rely on who has the sort of most power or authority in a situation, it just breaks down and doesn't serve anyone well. And what collaborative problem solving is about assuming the best intentions from all parties involved, remembering that people do well if they can, that we're all doing the best we can to handle what the world is throwing at us with the skills that we're able to bring to bear in that moment. And that when anybody, a child, an adult, a treater, isn't behaving so adaptively, they probably have good concerns and good reasons. And we want to try to get to the bottom of that. And let me tell you, I have been involved in conversations where people trying to collaborate around someone's mental health, where it has actually been the provider who has lost control of their ability to manage their behavior.
Mm.
And so, we're all doing the best we can, but we can collaborate well if we start from a position of empathy, compassion, and curiosity.
Mm.
And we try to resist the urge to sort of impose our will when we have solutions in mind that we think would be helpful, because frankly, imposing solutions on other humans never works well.
Dr. Ablon, I love those three tenets of collaborative problem solving, and I would ask you to repeat them so that I can sort of frame up a question for John.
All
They
right, I'd
are
be happy to
empathy.
repeat.
Yeah, empathy. They are empathy,
Compassion, I think I said, and curiosity.
curiosity. Okay.
Yes.
John, let's take a normal intake for a young adult who comes into psychiatric care. His parents have finally referred him in because he's been violent toward them. He's been self-harming. He hasn't been going to work or contributing toward any of his duties or obligations. He is going to tell the intake team, I don't want to see my parents. They're a pain in the ass. Okay? Frame what Dr. Avalon just said. Instead of saying, that's great, that's fine, you're on your own here, and your team and I will figure it out. How do you employ empathy, curiosity, and compassion in framing a new collaborative problem solving method? What would you suggest the clinical team do?
So that's a very common experience.
Yeah.
Right? That's the first thing is that they're going to come in and, for a lot of complex reasons, I think framing this still that people are going to do the best they can. They may have some reasons in their mind that they want to make sure that the team knows that their parents are difficult, right?
Right.
So the first thing is not to get into any type of power struggle or debates. So try your best to join with that person. And you can do so in a skillful way that's not necessarily agreeing with everything they say,
Mm.
right? So it's a little bit of, kind of the almost a little bit of the leap method, right? You can listen, empathize, you can agree that they are really upset, that they're really struggling. You don't necessarily have to agree with all the details. You don't have to agree that they're an asshole, right? The
Yeah.
parents, right? But you really want to partner with them because the truth is, if you try to approach it in a way that's based on disagreement, blame of them, you're not going to get anywhere and you're not going to be able to accomplish anything. So you can still empathize and agree and be compassionate without necessarily agreeing with everything that they're saying. And you have to be able to join with them.
I
Dr.
think
Avalon, yeah.
what John's describing there is so important because, I think we often misunderstand what the word empathy means.
Yeah.
And we often think that the only way you can empathize is if you really join by agreeing. And that's not the definition of empathy at all,
Mhm.
right? Empathy is neither agreeing nor disagreeing. And I always point out to folks, you can patently disagree with somebody, and still empathize with them. I've worked with folks who are actively psychotic and are describing delusions that are delusions. And you don't have to disagree with them. You can understand what's going on for them. And that is empathy. You don't have to agree. You don't have to disagree. You can just unpack and understand. So fundamental to empathy is listening. It's asking questions. It's gathering information. So, I say to folks, whether you're the parent, you're the provider, whether you're doing that clinical interview, your job should be to be curious, to be sort of a detective and just try to gather information. And you don't need to take a stance. You'll get a chance to say your piece on your perspective. But for starters, just learn and understand.
Dr. Ablon, one of the things that I have noticed is, especially because insurance payments are so sparse now, the inpatient stays are being limited to sometimes 15 days rather than a month. A 15-day stay is now 2 to 3 nights, if that. And so part of this, I am sure, if we look at it from a clinician's perspective, is just ease. They're trying to make their path forward as conflict-free as possible.
Yeah, and it never works, and
right.
it only makes it harder and produces more work.
Yes.
Often it's kicking the can down the road. I mean, you could, in your hypothetical example, you could agree with the child, the adolescent, young
Yes.
adult, and you might, temporarily sort of gain some buy-in from them that looks like, wow, that was a quick and easy clinical interview. But just wait till the family gets involved, and now it's going to get ugly. And
Yeah.
so, it's an old story, but taking more time up front is going to save you time down the road. And that is true wherever you try to problem solve. That's just fundamental.
I just love the idea at looking at all of the people involved in a mental health crisis, because when one person gets sick, entire family models get sick as participants, not perpetrators. And I think one of the questions that I would have is for families that feel a burgeoning psychiatric crisis coming on before they have to send their kid or their partner or their loved one to care, how could you use this model in the home, Stuart, so that we might all be able to bring the temperature down a little bit, see one another's perspective, and really understand where we're coming from?
Yeah, absolutely. Well, look, we know this because we do this in many places, including our largest national partner, sends people into homes to help teach them collaborative problem solving to try to avoid inpatient or residential stays. And they do this rather successfully.
Wow.
But what does this look like? Well, it looks like instead of coming in and focusing on whatever behavior people are concerned about, it looks like trying to pay attention to what are the expectations, the demands, the situations that a child is having a hard time managing. Forget how that manifests itself in terms of some form of behavior we're not wild about, but what are they having a hard time handling and why?
Yes.
And the why is really focused on skill, not will. It's focused on what are they struggling with skill wise that if they were able to pull off in those moments, they'd be able to handle these situations a little better. And that allows you to join with people in a compassionate way and then start the process we were just talking about, which is get information. Try to be open-minded, be curious, don't be judgmental, and really try to understand what's going on. And that's the beginning of trying to get some collaboration off the ground that might be able to avoid a higher level of care being needed.
Oh my gosh,
Yeah.
I'm loving what he's saying. Go ahead, John.
Yeah, absolutely. No, I just wanted to jump in there. So that's so well said. I think a lot of, we'll say, traditional treatments focus on the typical medical model where like there's this problematic behavior and a symptom, and so let's create a treatment plan isolated just for that, as opposed to looking at the system as a whole. One of the reasons why I love and have loved my social work education so much is because like the frame that social work sees things through is called person and environment, right? So you want to look at the whole environment, the why behind it, how you can step in instead of just focusing on one specific issue. And then, of course, families are going to be much more open to working and engaging with somebody, and same with the kids that may have had the problematic behavior.
Boy, this thing about, all of the issues, like I've said, so many of the families that I see that are in inpatient psychiatric care, if we'd been able to catch them 6 months, 12 months earlier, help them with their mortgages, help them with their lack of sleep, help them with just the dynamics that create this mental pressure that cause people to kind of have that break. I just think we'd be able to redesign the entire system, and that would be the social work end. But you have to be in really dire straits to get the attention of the social work system at this point. So, Dr. Ablon, I am in love with the collaborative problem solving method, and I think you are doing the most important work that's out there in mental health right now. How can families learn more about your system? How can they start engaging with the ideas in their own family structures? And what would you suggest for people who already kind of feel this tension and fear and sort of hopelessness around a family member's mental health status?
Yeah. Okay. Well, you're asking a lot of questions there. Let me see if
I
I can
know.
remember them all. And thank you for the kind words about our work. And our work is a product of collaboration itself, with many people doing incredible work out there. I think perhaps the sort of the fundamental concept that I mentioned earlier, the philosophy behind this work is what's most important to hold on to in the darkest moments, which is the notion of, if you're a parent and concerned about your child, it's the notion of kids do well if they can. Because the worst thing you can do is start to blame the child. And remembering that your child is doing the best they can to handle what the world is throwing at them is crucial. And they might not be handling it well, but they're doing the best they can. I've never met a child that prefers doing poorly to doing well. I've never met an adult that prefers doing poorly to doing well. So holding on to that will allow you to stay in a compassionate place where you can be connected. But there's all kinds of resources that people can use to learn about our approach. The program that I have the privilege of directing at Mass General Hospital is called Think Kids, and on our website is a ton of resources for parents and other people as well. We've got parent classes, we've got brief on-demand courses people can take. We've got a list of providers, people who are certified experts in the approach around the world. So I really encourage people to check out those resources there and to connect with other parents. This is one of the things that we're constantly trying to do, is create a community of people who are supporting one another, because the kinds of things we're talking about today, wow, is that a lonely, lonely place to be. And when you're fearful, you're worried, you're uncertain about how to navigate things, and you feel alone, my goodness, is that overwhelming. And so being connected with other people who are at different stages of this journey and can provide some support, some guidance, can be critical as well. So we're really trying to create, a community around this work as well.
Yeah, it's phenomenal. John, if you were able to kind of redesign psychiatric care, where it is that you refer your patients to, and to include some of these ideas that to me are so hopeful and so optimistic and beautiful, what would it look like? How would the system be different?
Yeah, wow, it's quite a loaded question.
They all are,
I would,
right?
yeah, they
Sorry,
are.
guys.
No, it's okay. I would, yeah, no, I mean, I would change quite a bit. When families reach out to me, they're already in a pretty significant crisis generally. So, certainly there would have been benefit of the collaborative problem solving program or some involvement in that. Either they didn't know about it, didn't have access to it, didn't engage with it. And so now they're in crisis. And so triaging that crisis is incredibly difficult. I think one of the hardest things, and there's so much to this, but there's some systemic barriers, right? There's managed care, there's low staffing. If someone's in a crisis stabilization unit versus an inpatient unit, is it insurance? Is it private pay? I mean, there's a lot of just systemic barriers that are incredibly difficult to navigate. People are burnt out. But I think one of the most important things, and I think is like a relatively easy shift, and depending on the program, it's easier to implement, and it's more of a cultural shift than it is anything else. And I really believe it's related to what we talked about earlier, which is this idea that like more collaboration is better, more involvement from family or other stakeholders, siblings, community members, to be involved and to really help. And so to know that we're going to take a collaborative approach and moving away from that kind of traditional pathologizing medical model, looking at them and their environment. And I think another thing that can really be shifted is to know that for anybody working in those types of higher level of care settings is you have this person for a very short period of time. And so instead of looking at like, okay, how do I deal with this person, right? Because that's often what it is. How do I deal with this person and this family for this short period of time is how do I return them back to their environment in a way that is sustainable, right?
Yeah.
So much focus is
Great
on
frame. Yeah.
the triaging the initial crisis, but like how do I return this person so that it is sustainable moving forward?
Yeah, that's such a great answer. John Stuart, last question is to you. If you're aware that this is happening to you when you're in the current system as it is, when they have told you we don't want you contacting your patient, they don't want to have anything to do with you, we see you as part of the problem here, what steps does a family member have?
Tough question. And first of all, let's just acknowledge when you're in that position, if a family's placed in that position, that is incredibly overwhelming to deal with.
Yeah.
Okay. So, I think the most important goal for parents in that context is to try to regulate their emotions.
Yeah.
So that they can approach this in the sort of best strategic way possible, or else it'll end up sort of making matters worse.
Yeah.
And this is where I'm going to sound like a broken record, but this is where, collaborative problem solving is not something that parents just use with children or providers use. This is something anyone can use under any circumstance where there's some conflict, where somebody's not doing something that you want them to do, or they're doing something you don't want them to do. And so in this case, what I would suggest is actually for the caregivers to initiate collaborative problem solving with the person who's saying to them, no, you're not going to do this, and no, you're not going to do this. And the safest thing to do instead of reacting to that is to try to start with curiosity. Because by the way, when you ask somebody questions and you take real interest in what they're saying, it regulates that person. Empathy is regulating. It brings them right down.
Yeah.
So you say, okay, I hear you. So you're saying that, we can't be a part of this process, and that our son doesn't want us a part of the process. Can you just, help me understand where that's coming from? I'm not saying that I'm going to, resist that. I just want to understand more and sort of how you, if you at all, how you see us fitting in. And maybe it's not, I'm just curious. And just ask for information. Okay. And the other thing I would say is when you ask for information, it gives you a little time to think too, right? Gives you a little time to think about, how do you want to express what you're worried about, your concern, and don't try to impose, no, I'm not going to do that. I'm going to do this instead. Because then you get what I call dueling solutions. No, try to understand their perspective, their concern, and then share yours and invite collaboration. Okay. And that might look like, okay, I understand you need to respect the law and HIPAA here. I totally get that. And just be clear, I'm not asking you to do anything differently. And not but, and, I'm sure you can understand as a parent, I'm really concerned about them and want to do anything I can do to support them. So I'm just wondering if you think there's any way that we can be involved that will be helpful, that will work within the law and within the constraints that you're under. What do you think that could look like? And I'm inviting collaboration.
Yeah, that's phenomenal. I wish we could get you to Congress, Stuart. It would be wonderful for you to teach this.
Well, the whole world could use some collaborative problem solving. There's no doubt about that.
That's right. John, do you have anything to add before we go?
No, so just to add on one part I wanted to touch on, Stuart, with what you just said, which is that I think people often want to be understood. And so, but they don't know how to express that need necessarily. And so by taking that approach and being more collaborative, asking those open-ended questions, seeking to understand, and meeting them with empathy. Empathy is incredibly disarming, as you mentioned, and so is seeking to understand someone's perspective. And what I've noticed is what may seem like a firm stance that they're not shifting from. If you meet people with empathy and understanding, they're much more likely to see a different perspective.
Absolutely. This is why, hostage negotiators talk about the use of tactical empathy, strategic empathy. It's disarming, it's dysregulating, and it opens up options and flexibility. So, well said.
Dr. Stuart Ablon and Dr. John Puls. Wow, what a wonderful session. I am so excited to have both of your voices out there. We'll have links to both of your websites and how you can contact you, and especially finding out more about collaborative problem solving on our website. Thanks again for being with us.
A pleasure. Thanks for having us, John. Great to have this conversation with you. Appreciate your collaboration.
Yeah, you too, Stuart. Thanks so much, Sheila.